All right, Sophia. So we have some, we already have some people. Um, Hi, everyone. It's a pleasure for me to introduce Sophia. She's a third-year resident from Rodolfo Robles, and she's actually doing her rotation in in Nuevo Progreso, San Marcos now. So, Sophia, can you tell us a little bit about yourself?
Well, like you say, I'm a third-year resident in El Rodolfo Robles. I'm starting here in La Familia. This is actually my last week. It was a very good month. I really like it here. I had the opportunity of to be in a jornada. We had Dr. Sima Kapoor, and it was very interesting because I get to see like different kind of surgeries that I love, and I get to learn a lot about her and all that she teaches with different cases that we see day to day.
Tell us about your hobbies.
Well, the few hobbies that I still have because of the residency, well, I love the jigsaws. Jigsaw puzzles?
Jigsaw puzzles?
Yes, I love it. I can be like all Saturday or Sunday, like concentrating doing it because I don't know, it calls me, but in the same time, it stressed me out when I can like get the pieces to connect. But I really like that.
She also liked to travel to Disney.
That's true. It counts like a hobby.
Nice.
That's funny. What's the biggest puzzle you've ever done?
Well, I haven't done like a lot like bigger, but I like to do like a lot of 1,000. I have a lot of that. The time.
Yeah.
Sometimes I will have a lot of time to do like, I don't know, 5,000 or well, 5,000, yes.
Nice. All
So,
right.
all right.
Yeah, but
Well, I'm going to start.
yeah.
Well, well, okay. We have this. I decided to choose this patient because I think it's a really interesting case. So let's start. We have this patient that it's a male of 20 years old from Catarina San Marcos. Her chief complaint was that he was referred actually by an ophthalmologist because he had like a corneal wound with an intraocular foreign body. The history was that 3 days ago, he was like cutting wire, and while doing this, he hits himself with the wire and felt something in her eye. He has no past medical history. In the physical exam, we had like a visual acuity of 20/50. The right eye, everything was okay. In the left, we had ciliary injection, a wound 2 millimeters supratemporal. Saddle was positive, and we can see the intraocular brain trap in the temporal iris. The anterior chamber was shallow, the pupil was reactive and round, the lens was actually intact, and the IOP was in 10. We did an ultrasound to verify that everything was okay in the posterior segment, and the ultrasounds was okay. So we have here like a video so we can see the brain body. As you can see here. Well, there you can see the brain body and the wound. At that moment, we thought that was maybe like a piece of wire when he was cutting, because that was That was what he was doing. As you can see. So we decided that day to close that wound. So as you can see in this video, sorry, I stopped there. We did it with retrobulbar anesthesia. As you can see, we made a paracentesis so we can reform anterior chamber with viscoelastic and extract the foreign body. And when we extract him, actually, we see that the foreign body was an eyelash, actually. And that's why I choose this patient, because when we did the physical exam, we thought that maybe it was the wire, but actually when we took it out was an eyelash. So we start to close the wound with 3 corneal sutures and see him the next day. The next day we had a visual acuity of 20/200. We had the ciliary injection, corneal edema, a little bit of cellularity. The saddle was still positive. So we decided that because we still had saddle, to went back to the operating room and for suture repositioning, but this time we use intracameral lidocaine 2%. And we started him with moxifloxacin and steroids eye drops every 6 hours. In his next visit, we saw him like this. As you can see in the picture, her visual acuity was actually counting fingers. We had a lot of edema. We had deciment folds, cellularity, saddle was negative, and the anterior chamber was deep. So at this moment, we started to think, well, maybe we had a deciment detachment, because we see here in the picture. So we decided to do an anterior segment OCT. Here is the OCT. As you can see, deciment is okay. So actually, in this visit, we had Dr. Kapoor with us for the jornada, and we started to discuss the case with her, trying to ruling out all the reasons for this reaction. And thinking of all the reasons that can be, we started to have high suspicions that maybe was an toxic anterior segment syndrome, secondary to the lidocaine that we use. So thinking in this, we started him with oral prednisone, 50 milligrams per day, steroids drops every 2 hours, continue with the moxifloxacin, and also added sodium chloride drops every 4 hours. And actually that helps a lot. In his follow-up visit, we saw him, he's still counting fingers, but as we can see, the edema really clear out. We had only deciment folds next to the wound, and he was feeling a lot better because he feels that his vision was more clear. So we decided to keep with the treatment and left him with a checkup 5 days. And as you can see in his last visit, he was with a visual acuity 20/16. It's a lot clearer the cornea. We don't see deciment folds, and he feels really better because his vision really improved. So we decided in this visit to eliminate the sodium chloride drops and started to tamper with the steroids. And we will see him in about 2 weeks, so we can start to eliminate the sutures to see if we can still recover more visual acuity. So this was the case that I choose. And to continue with this with this case, I'm going to talk about a little bit of toxic anterior segment syndrome. We know that this is an acute, rare, sterile, post-operative inflammatory reaction of the anterior segment without vitreous involvement, following an uncomplicated and uneventful ocular surgery. This can be various cases of this, as you can see, irrigation solutions or ophthalmic viscosurgical devices, ophthalmic instruments, contaminants, ocular medications, and intraocular lenses. There are like a lot of causes that can give us a task. With these patients, they are going to present with blurred vision, mild ocular pain, redness, prominent severe limbus to limbus edema, like our patient, as we saw in the picture. These patients also can have severe anterior chamber reaction with fibrin or hypophobion. When we have these kind of patients, we also have to think about the differential diagnosis, because it can change a lot the prognostics. And these kind of patients, we also have to think with an endophthalmitis. But we have to remember that with anterior toxic syndrome, that they have no pain, the onset is within 24 hours. We're going to have the limbus to limbus edema, because we have to really differentiate these two entities, because with TAS, we have to be like really aggressive with steroids, because they improve a lot with topical and oral steroids, typically within 1 to 3 weeks, like our patient. But if it's an endophthalmitis, we may worsen the clinic. So with this kind of patients, the treatment, topical steroids every 1 or 2 hours, the psychoplegics, non-steroid anti-inflammatory agents, and the oral prednisone. So to take home points, we always have to make sure that the dilutions that we have to use in different medications that we apply inside or outside in the eye, and always recognize and be aggressive with these patients, because they can improve a lot with the right treatment. Thank you.
Hey, Sophia, can you go back to the photograph? First of all, thanks for sharing that case. It's really interesting. We've had a couple of cases in our residency program here of retained eyelashes or cilia in the anterior chamber. And I remember one doctor presenting a review of these retained cilia, and the question was, you know, how dangerous is it just to leave it there? And one of the interesting things that comes up with these post-trauma eyes is how that cilia gets in there, and what is supposed is that as the injury is approaching the eye, the patient blinks their eye, and then that the trauma, whether it is a rock or a piece of wire, it drags an eyelash into the eye as part of the eye blinking, and then gets stuck in the eye. But in this photograph, I see the eyelash. Is there a foreign body also? Is that the second piece?
No. That's what we saw, and think maybe it's the wire. We never thought that maybe it was an eyelash after we took it out.
I see. So there's nothing else in the eye. It's just the eyelash.
No, it's just that.
So if going along with that same mechanism of injury, it seems this eye probably had something sharp hit the eye and it dragged the lash in. I think it was George Tanaka presented a case like this, where they just left the lash. The lash had been there for a long time, so Has anyone else seen a lash in the eye? Is that a this must be the fourth lash that I've seen presented like that. You have, Jorge? Yeah. I assume you.
During the residency, we would see in the trauma cases and in the corneal wound cases, we would see those, but we would always take them out.
Yeah.
We wouldn't leave them. Yeah.
Because this eye looks pretty quiet right now, doesn't it? It's not. Yeah. It's surprising. It's always surprised me that they're not infectious, or that they generally don't track infection into the eye. It seems like they should. So, and then the edema happened after the removal.
After the removal, when we took him for suture repositioning because he still had Sadel positive.
And the edema happened, and you think it's because of the lidocaine?
Yes, yes. And this is the picture with the edema. Ah, okay, sorry. Here.
And what was the lidocaine that you used in the eye?
We use lidocaine 2%.
Not so preserved 2% lidocaine.
Without preservative, Dr. Sorenson.
So to just 2% not preserved. That's so interesting.
Yeah. But after we have this case, sorry, this is Pamela from Claudia's cell phone. But what Sophie was saying is that the next day when we saw, like the first time we just placed the sutures, the next day, actually the cornea was clear just with Sadel. So I decided to put it back in the OR to put another stitch so we can close the eye. But this time, because it was just a suture, I used this lidocaine 2%. And actually, we have been using it like that, like lidocaine 2%, like no preservative. But after this case, we review, and most of the review that we have checked, they're using lidocaine 1% for intracameral use. And I don't know why we have 2%, but actually today we use in another patient lidocaine 2%, and this time we diluted. Yeah, so now we made a concentration of 1% with the one we have.
Yeah, as soon as you inject the 2% into the anterior chamber, it's no longer 2%. It's diluted quite a bit. And same with the 1%. As soon as you inject it, it becomes 0.1% or 0.01%, 0.05%. It's so I do. Does anybody else think that this is a lidocaine toxicity? No response. Yeah, I don't know. I'm. What else could it be that would cause the? Did you hydrate the eye or and I'm wondering, was there?
We didn't do anything different. The only different thing that was that lidocaine.
Yeah. Well, that's interesting.
What about the what was the eye pressure before and after? Because maybe if it was Sidel positive, the pressure was low, and then once it stopped having Sidel, the pressure went up and then caused some edema.
The IOP was always normal.
Oh, great.
Mira, es difícil, vos.
And there was not a decimase
Hay
membrane
suegras que sí les
detachment.
gusta organizarte como algo muy de ellas, que se note que es como que de tu suegra.
There's no decimase membrane detachment. Did you do a literature search on 2% lidocaine causing toxicity?
Yeah, Dr. Sorenson, we tried to look for it. There was just one article that talks about it and said it is not, I mean, they cannot prove that it's safe or not.
Yeah.
That's the only article that we found, and the rest of articles are from lidocaine 1%. I mean, we are presuming it was because of the lidocaine 2%. We are not completely sure, but usually TAS is like when you rule out everything else.
Yeah, we've done a lot of work on TAS, and this doesn't really fit the description of TAS because TAS would presumably be from some contamination or some type of a chemical that would induce an inflammatory reaction, usually with a hypopion or fibrin. It looks like you had some acute endothelial toxicity. And that it sounds like that's your diagnosis is endothelial toxicity from lidocaine. I wonder, is the lidocaine, do you have a sense as to is it expired, like an older batch of lidocaine, or um was it with epinephrine maybe, or was there something else in it?
No, just lidocaine 2%, and it's not expired.
Not, yeah, that's so much thing.
Sophia, question. You mentioned that it was referred by another ophthalmologist. Did they specifically send the patient to us at the hospital? And if so, where did the ophthalmologist practice? And lastly, were you able to communicate back with them about the results of the patient?
Well, yes, he referred to us because he was with low resources. And he was a doctor in
Coatepec.
Mhm.
And were you able to get, I just think it's interesting because I don't think we get a lot of referrals from other ophthalmologists, even though we have all these other services there. And it's just interesting to try to nurture the relationship with the local ophthalmologists. And I think it would be nice if you had a chance to communicate back with them about what you did and how it all worked out as a way to build relationship with the local folks. Because I love the fact that they sent them to us for care.
Here's there is one article here on corneal endothelial toxicity following, topical anesthesia, topical, like people have injected a lot of things in the eye. So this article here is, this article studies bupivacaine, non-preserved 4% lidocaine, proparacaine, tetracaine. So, I mean, there's a lot of things that you can't safely inject into the eye. So it's good to know what that list is. Maybe another thing that comes from this discussion is, what can you safely inject into the anterior chamber of the eye? What would that list in your mind be, Sophia? What can you inject into the eye safely?
Viscoelastics,
Yeah, viscoelastic.
saline solution.
Yeah, saline, balanced saline. How about sterile water? Anyone on sterile water?
I don't know.
Sterile
Maybe
water is a real bad one because it's has a different osmolarity than the balanced solution. So you'll definitely cause corneal edema if you sterile water. Another one that's very dangerous is everybody uses Vision Blue and Trypan Blue, but how about I think it's called it's another blue dye that's used for marking tissue with, and it's commonly found in general surgeries. I can't remember the name of it, but it's a different kind of blue. Has anyone ever encountered that? Because we had a doctor inject that blue dye into the eye.
It's not gentian
It
violet?
I don't think it's gentian. It might be gentian violet. But it comes in a blue vial. It's liquid. It looks just like Trypan Blue, but it's not. And that can cause acute corneal decompensation. So you don't want to do that. And Vigamox is safe, but what about moxifloxacin? Any ideas on that one? So moxifloxacin, non-preserved moxifloxacin is okay, but moxifloxacin from a bottle, like you would use topically on an eye, you can inject Vigamox directly into the eye, but if you inject moxifloxacin because of its preservative, that causes corneal endothelial decompensation also. So it just seems like something had to have caused that cornea to decompensate. It just doesn't. It's hard to think that 2% non-preserved lidocaine would all by itself would do that. Anyway, I just have to look into that a little bit more. Oh, methylene blue. Yeah, thanks, Rebecca. Methylene, that's it, exactly. Methylene blue. We had a doctor inject methylene blue into the eye, and the patient needed a corneal transplant. So that's a no-no. I should add one more comment is on TAS, since we've written on that extensively, is that TAS has this huge list of things that cause it. But the main cause, other than contaminations that are known, the main cause is from autoclaves that have that have contaminated reservoirs from which the steam is produced. So if you're using like a Statim tabletop autoclave, one of those small autoclaves. So if in this case, for example, you used an instrument to go into the eye, and the instrument had been given to you from an autoclave that was contaminated, the autoclave can pass to that instrument some toxins that can cause TAS. So anyway, this just didn't seem like TAS to me, but it's hard. Sometimes it's hard to tell. Anyway, that's a great presentation, Sophia. There's a lot of questions from this type of a case that hard to answer.
Yes, it was really interesting.
How long are you going to leave those sutures in the cornea for?
A month.
1 month? Yeah.
Yes.
Mustafa, what would you do?
Yeah, I was thinking, yeah, at least like 6 weeks or so.
Yeah, those are nice. Those are nice sutures, though, nice and long. So,
Sophia, I'll be there in November with Andy, so you can put him on my schedule for a specialty contact lens. We can bring him back to 2020.
Yes, we can do that.
Okay.
thanks a lot, Sophia. Nice case.
Thank you.
Yeah, great case. Nice discussion, Andy. You have a lot of experience with TAS. I hope not, but you've written a lot about it, though. I remember your paper. Have you had any feedback on that paper with Dr. Chang?
Yeah, we've written kind of three papers on this. One is on TAS and one is on diffuse lamellar keratitis that you see in LASIK. And we've, that's maybe the topic for a separate grand rounds, but the punchline is that that the main, what we think is the main culprit, and everybody who's operating around Central America or in the United States should be aware of the role of these small tabletop autoclaves, specifically the Statim G4 and the Statim 5000 and the Statim 7000, those autoclaves that have these little fluid-filled reservoirs. Those reservoirs they almost all produce a broad contamination, and then that contamination gets passed into your reservoir. So that's something that we're just last week, someone called me up from Northern California with a very advanced case and they had that problem with their autoclave. So it's a very common problem. And one other thing I'll say about TAS is it typically happens after your autoclave has been sitting unused for a month, like after a vacation or after a long weekend, and you're the first one to use the autoclave, and your autoclave cleans your instruments, and they give you the instruments on Monday morning, and you're the first one to use them. Those instruments can be contaminated with all these toxins. And later in the day or later in the week, maybe the autoclave gets purged and cleaned out, so you don't have the same problem. But that's something to be aware of. If you ever run across that, call me up. we'll
I think TAS should be renamed Toxic Andy Sorensen Syndrome.
Oh yeah, that'd go over well. That's really funny. Yeah.
So do you routinely, if you're out for an extended period of time, would you recommend just making sure that the autoclave is, before you come back and operate, make sure the autoclave is cleaned out?
Yeah, so the way to deal with this is the autoclave has a reservoir on top of it, and when you look at where the fluid is stored, what you have to do is you have to create a maintenance cycle for your autoclave. And what that should involve is once a week draining the fluid and then pouring boiling water into that reservoir, letting it sit for 2 minutes, and repeating that at least 3 times once a week. And then in addition, conducting surveillance. So at our center, we have blood agar plates that we use to culture the autoclave reservoir whenever we operate. So once a month anyway. So we'll culture it. And we just bought a brand new autoclave from the company that makes that autoclave, and it arrived to us pre-contaminated. So we cultured the reservoir when we bought it, and it was already producing lots of fungus and bacteria. So anytime you have water that's not sterilized with alcohol or bleach or heat, that water will become a place where bacteria and fungus start to live. And it happens in every body of water around the world. So we're not sure about the moon, but it happens around the world if you have water there. So yeah, so Mustafa, you want to have wherever you work, you want to have. Do you have tabletop autoclaves where you're doing your fellowship?
Not where I'm doing my fellowship, no.
Yeah. So I went around to 20 different ASCs in Northern California, and 18 of 20 of them, the autoclaves were contaminated.
Mm.
So it's a wide problem, and it's still not. Jorge knows this. We wrote it up, and it was published, but it was published in March 2020, which is not a good time to publish something if you want to get any attention. So it basically all the effort to publicize this has just kind of got kicked to the side. So we're going to try to animate the discussion about it, but it's still a big problem. Yeah.
Thank you.
Yeah. Thanks, Mustafa.
Thank you, Andy. Thank you, Sophia. We're right on time a little bit, but thank you, everyone.
That's great.
Yeah, it was great, really great. We'll see you next week. All right.
Thanks, everybody.
Good
Bye.
night,
Thank you.
everyone.
Bye. All right.
Bye. Good night.
Goodbye. Bye, Caro.